Hi guys, welcome back to the today's discussion. Welcome back to the channel. In fact, so the objective of today's discussion is to set the ball rolling. That is, talk about electrolyte imbalance, and the message that I would like to give is to set achievable goals. I think that's one of the most important thing that really matters because most of us set up targets which are really unachievable और वी ट्राई टू स्ट्रेच हम कोशिश क्या करते हैं कि भाई बहुत ज़्यादा पढ़ लेंगे या बहुत ज़्यादा टारगेट्स हम क्रिएट करने की कोशिश करते हैं तो आई थिंक अगर हम थोड़े से रियलिस्टिक टारगेट्स बनाएं तो दैट वुड ऑलवेज बी एडवाइजेबल एंड उसके बेसिस पे यही होता है मतलब वो अचीवेबल टारगेट्स होते तो खुद को भी अच्छा लगता है कि या आई एम एबल टू फिनिश अ पर्टिकुलर सब टॉपिक और आई एम एबल टू फिनिश दो सब्जेक्ट्स खासकर which are always a sore point because now is the time, December is the time when we are a little casual before the exam because New Year is going to be around the corner and then I mean it's more of a festive season, shaadiyan chal rahi and everything. So most of the time doctors are going to be the only ones who are going to be sitting in a room and listening to let me say me discussing about electrolytes, but that is uska bhi apna hi thrill hai, not everybody is capable of doing this. So I think we can get started for today with these words. मतलब मैसेज मेरा ये रहेगा सिंपल भाषा में कि भाई बहुत ज़्यादा एम्बिशियस नहीं होना है. ट्राई टू सेट अप दोज टारगेट्स जो आप अचीव कर सको ऑन अ डेली बेसिस और उसी के लिए सीरीज स्टार्ट करी गई है. एंड आप कमेंट कर सकते हैं चैट बॉक्स में विद रिस्पेक्ट टू कि कल कितने जो भी क्वेश्चंस मैंने डिस्कस किए तो उसमें से कितने आपके सही हुए and were you able to solve those questions in the very first place. मतलब वो फर्स्ट अटेम्प्ट में आप सही करा या सेकेंड में अटेम्प्ट किया तो do try to evaluate that, that is an important aspect. और आज हम इलेक्ट्रोलाइट्स में जो टॉपिक पढ़ेंगे सबसे पहले that's gonna be very good evening, that's gonna be hyponatremia. So I think I missed out a couple of names there, Shruti, Abhijit, Sporothrix, Petsword. I have completed Pet's Word. Your message was a little hidden, so I'll just look at it. Doc, as I said, try to do daily job. Okay, great, Saurabh. If you were able to get them correct, then it's great. Hours would be, I think, 12 to 14 hours are the minimum that you should be studying. I think उससे कम तो बनता ही नहीं है. राइट क्योंकि 6 से 7 घंटे तो थ्योरी में ही लग जाएंगे एंड देन यू हैव टू प्रैक्टिस एमसीक्यूज एंड इन 1 आवर पर्सन कैन डू मैक्सिमम अबाउट 12 to 20 MCQs depending on your reading speed with explanation बोल रहा हूँ because see reading a question itself will take about a minute or so then you have to read the explanation also. So if I say 3 minutes per MCQ with explanation, that means maximum 20. So even if you're doing 6 hours per day, maximum you can achieve is 100 to 120. Obviously gradually the speed will pick up. So yes, Shreyansh and a lot of other people are joining. So I think we are good to go for today as far as today's discussion is concerned. वो टॉपिक्स पहले पढ़ लेना जो मतलब ना people tend to skip. तो हाइपोनेट्रीमिया 3 प्रकार का होता है जैसे आप जानते हैं, हाइपोवोलेमिक, यूवोलेमिक और हाइपरवोलेमिक. तो हाइपोवोलेमिक का मतलब क्या होता है कि भाई उसमें बॉडी में सॉल्ट की भी कमी होती है, वाटर की भी कमी हो जाती है और सबसे जो बेस्ट एग्जांपल है उसका डायरिया, वॉमिटिंग, फिस्टुला. बाकी एक टेक्निकल याद कर लेना. जो चौथा कारण मैं आपको बता रहा हूँ दैट वुड बी सीन इन पेशेंट्स दैट इज सेरिब्रल सॉल्ट वेस्टिंग सिंड्रोम. हाय शुभम, दैट इज ग्रेट. सो ट्राई टू अचीव मतलब 100% ही हो जाना चाहिए क्योंकि मैंने जो क्वेश्चंस डाले थे वो रिलेटिवली ईजी थे as far as yesterday is concerned. So I think 500 MCQs daily. Doc, I don't think so. It's practically possible to do 500 in a day, unless and until we are just cramming up answers for the same. Yeah, Shreyansh, I'll be doing that subsequently. But anyway, we are just focusing on hyponatremia at the moment. तो भाई हाइपोवोलेमिक में पानी की कमी हो गई है तो क्या करेंगे, तो रिंगर लैक्टेट देंगे या नॉर्मल सलाइन दे सकते हैं या फिर ORS दे सकते हैं. सो हाइपोवोलेमिक इज प्रीटी स्ट्रेट फॉरवर्ड. इट्स पॉइंट नंबर 4 दैट इज टू बी रिमेंबर्ड. ग्रेट स्कैल्पल, यू डिड अ ग्रेट जॉब यस्टरडे. एंड यूवोलेमिक का मतलब ये नहीं होता कि बॉडी में वाटर नॉर्मल है. यूवोलेमिक का मतलब होता है वाटर बढ़ गया है. तो वो क्यों बढ़ता है? एंटी डायूरेटिक हार्मोन की वजह से. तो जो सबसे इंपॉर्टेंट कॉज आपको आपके एग्जाम के लिए याद करना है यूवोलेमिक हाइपोनाट्रीमिया के लिए वो है SIADH, सिंड्रोम ऑफ इनएप्रोप्रिएट ADH सिक्रीशन. प्रणाम प्रमोद. एंड पानी इसमें नहीं देंगे, इसमें पानी नहीं देंगे. यूवोलेमिक हाइपोनाट्रीमिया में पानी नहीं देना, 2 जगह पे पानी नहीं देना ना. वही तो कंसेप्ट है कि भाई ये सवाल हम क्यों पढ़ रहे हैं या ये टॉपिक क्यों पढ़ाते हैं कि भाई हाइपोनाट्रीमिया का वो कौन सा मरीज होगा जिसको पानी नहीं देंगे, तो यूवोलेमिक और हाइपरवोलेमिक वाले को नहीं देंगे. अब यू वॉल्यूमिक का सबसे इंपॉर्टेंट कॉज SIADH होता है, और SIADH का सबसे इंपॉर्टेंट कॉज CNS इन्फेक्शन आंसर करना, मेनिंजाइटिस, एंसेफेलाइटिस, और जो हॉट फेवरेट है आपके एग्जाम का ना, दैट इज गोना बी मेनली cerebral toxoplasmosis, because he's usually most of the time gonna talk about a AIDS positive patient who's gonna be having seizures as well. So the important cause to be remembered in a AIDS positive patient with hyponatremia, that's euvolemic hyponatremia, would be cerebral toxoplasmosis. So these are like couple of reasons, and yes, you are right. I mean, I'm getting correct answers in the option also, that we'll be using like tolvaptan in the patient. So vaptans are the main offense that you'll be using for your patient. And as far as right hand side is concerned, hypervolemic, it's going to be mainly aldosterone that's going to be elevated. So if aldosterone is more, salt is also more, and the water in the body, I mean total body water will also be more. Both salt and water both are going to be increased. And what you are going to do in this patient on the right hand side is going to be spironolactone, that is diuretics. So right side का concept ये है कि भाई most of the time if he's going to put up a question, he's going to ask you regarding the extreme right hand side. Hi doctor's journey, very nice. स्पार्नोलैक्टोन डायूरेटिक्स, तो कौन सा सा हाइपोनेट्रीमिया होता है जहाँ डायूरेटिक इस्तेमाल करते हैं, तो आप बोलना हाइपरवोलेमिक। क्यों? क्योंकि एल्डोस्टेरोन बढ़ा हुआ है, तो एल्डोस्टेरोन एंटागोनिस्ट दे देंगे। और यू वोलेमिक वाले में क्योंकि एंटी डायूरेटिक हार्मोन बना हुआ है, तो हम एंटी डायूरेटिक हार्मोन को ब्लॉक करने के लिए वैप्टन्स उसको दे देंगे। हाइपोवोलेमिक नहीं पूछेगा, आई डोंट थिंक सो। आई मीन मोस्ट ऑफ द टाइम इन द एग्जाम इट्स अनलाइकली दैट ही इज गोना आस्क यू अबाउट द हाइपोवोलेमिक कंपोनेंट। तो आपने पढ़ना क्या है? मेनली यू वॉल्यूमिक, सिंपल सा कंसेप्ट है, एंटी डायूरेटिक हार्मोन्स आर गोना बी मोर, एंड इन हाइपर वॉल्यूमिक इट्स गोना बी बोथ सॉल्ट एंड द वाटर इन द बॉडी आर गोना बी ड्रामेटिकली इंक्रीज, सो आई विल बी यूजिंग डायूरेटिक्स इन दिस पेशेंट. So great, I think most guys got it right. Let's solve an MCQ now, and the question talks about this 30-year-old lady. She's having vomiting and the worst headache of her life, and CT is showing blood in the sylvian fissure. So the moment I read the MCQ, I know that I'm dealing with a question on subarachnoid hemorrhage. Though, I mean, we read about thunderclap headache in multiple conditions. So thunderclap headache is not only seen in subarachnoid hemorrhage, but thunderclap headache is also seen in stroke also. So don't be under impression that थंडरक्लैप हेडेक, मतलब थंडरक्लैप हेडेक का वैसे मतलब क्या होता है? चलो चैट बॉक्स में कमेंट करोगे दैट थंडरक्लैप हेडेक पर से, आई मीन व्हाट डू यू मीन बाय दिस थंडरक्लैप हेडेक? आई मीन हेडेक तो यार बड़े सारे होते हैं, तो थंडरक्लैप हेडेक का मतलब क्या होगा? थंडरक्लैप हेडेक का मतलब होता है द पीक इंटेंसिटी ऑफ द हेडेक इज गोना बी अचीव्ड विद इन ऑलमोस्ट एज लिटल एज 60 सेकेंड्स। कि जैसे अभी पेशेंट बिल्कुल नॉर्मल है, राइट? अब मैं आपके सामने बिल्कुल नॉर्मल हूँ, सडनली मैं अपना सिर पकड़ के बैठ जाऊंगा, एंड सडनली आई एम होल्डिंग माय हेड बिटवीन माय हैंड्स। सो इफ द पीक इंटेंसिटी इज ऑब्टेन्ड विद इन 1 मिनट, नो इट्स नॉट डॉक्टर, इट्स नॉट थ्रॉबिंग हेडेक. Throbbing headache is pulsatile headache that is seen in migraine also. Meaning of the word thunderclap headache, I mean worst headache of my life is like an English description, bro. So unbearable, exactly. So confused medical, the point is, you know, when I say unbearable headache, it will depend on tolerance of a person also. Some people have more pain tolerance, some people have like थोड़ा सा भी पेन होता है वो हेडेक बोलना शुरू कर देते हैं. So it's like not based on individual assessment, it would be based on peak intensity within 60 seconds, and he says which of the following would be seen in the patient. So yes guys, I think most people have got it right. Vomiting की वजह से इस पेशेंट को हाइपोकलीमिया हो जाएगा. हाइपोकलीमिया is present in all the options, and then more importantly because there is going to be release of B type natriuretic peptide, so BNP and P will be causing natriuresis, and because of this natriuresis component there is going to be loss of salt from the body, there is going to be loss of water from the body, and because salt is also less and water is also less, so this would fit into hypovolemic hyponatremia. Yeah, Dr. Parvez, it's like not within seconds, it would be by 60 seconds or so. No doctor, it will not normalize, obviously it will not be normalizing. So I can rule out, I mean two options can be ruled out in this case right away. It cannot be hypervolemic because we are losing both salt and water from the body, and it can't be euvolemic because it's not related to antidiuretic. So either you have to select between hypovolemic or you have to select between hypotonic hyponatremia. So in this case, it is not the tonicity that is affected, it is volume depletion which is present in this patient because of the natriuresis component, which is why I think most guys have been able to answer this one correctly. So I think we are sorted for this particular question. The answer for this one is option number B, and let's now focus on the next one. This is another one. Let's see how many of you get this one correct. He says isolated cortisol deficiency would lead to all of the following except. So the logic for this is what I'm going to explain to you, that cortisol has a inhibitory control over the release of antidiuretic hormone. Inhibitory control over the release of antidiuretic hormone. Antidiuretic hormone is produced by our hypothalamus, released from the posterior pituitary. So the main function of cortisol is gonna be inhibitory control of antidiuretic release. I'm getting a C initially for the current question on the slide. See, cortisol deficiency will contribute to decrease of sugar, no? Because cortisol helps in maintenance of blood sugar. So cortisol deficiency will be contributing to hypoglycemia. I mean, cortisol controls blood sugar, right? I mean, I don't need to even write that. Cortisol is the main hormone of our body, which is one of the important hormones in the body after, I can say, glucose and insulin, which is going to be helping in regulating blood sugar. So the answer cannot be C in this case. Cortisol deficiency will contribute to hypoglycemia. Cortisol is the stress hormone. The question is saying except. And then another inverse relation that you can remember is cortisol is always inversely related to eosinophil count. That again is a hack that would always help you in the exam, because अगर आप किसी को steroid दोगे तो immunity जो होती है वो कम हो जाती है ना. तो if you give dexamethasone to somebody, eosinophil count will become less, and the reverse is true. If cortisol is gonna be less, eosinophil count will begin to rise. So ये दोनों तो मिलेंगे. C will also be present and D will also be present. Both C and D will be present in the patient. The logic to remember D is cortisol is inversely related to immunity. If you have more cortisol, if you give steroids to somebody, no, immunity will become lesser. Vice versa, if cortisol decreases, the eosinophil count tends to show a rise. I mean, that's one hack to remember it, right? So C and D both are gonna be correct and seen in this patient. I think you guys should be able to understand cortisol as an inhibitory control over the release of antidiuretic hormone. So if cortisol will become less, that means antidiuretic hormone will be more. If antidiuretic hormone will be more, it will cause more water to come in the body, and more water in the body will then result in development of hyponatremia. So even sodium will be less. Guys, the answer for this one is option number B, that is going to be hyperkalemia. आपको logic से निकालना था. Cortisol has no role on potassium values. I mean, the hormone that will be regulating potassium values is aldosterone, right? I mean, read the question once again. Isolated cortisol deficiency. So cortisol has no impact on potassium. See, the hormone that will be controlling potassium values with respect to the adrenal gland is aldosterone. And I've said aldosterone will be directly related to sodium in the body and will be inversely related to potassium in the body. Like if you are having Conn syndrome, then salt in the body will start rising and potassium will become lesser, and vice versa. So you need to get the logics right in this particular case. And why is hyponatremia present? उसका मैं logic बताया that cortisol is gonna be having an inhibitory control over ADH release. If the cortisol itself is not there, then the ADH release in the body will tend to rise. More water will cause hyponatremia in the patient. So the correct answer for this one is B. I think that's more of a silly mistake that happened, and I think you guys can try and avoid that kind of a silly mistake from happening. So I think we sorted for this one. Try to I mean ये पढ़ लेना यार इसको ना. देखो पोटेशियम को रेगुलेट कौन करता है? तो अल्डोस्टेरोन करता है. सिर्फ उसी से अगर आप इतना याद कर लेते हो ना, पोटेशियम का रेगुलेशन अल्डोस्टेरोन से है. दैट अलोन इज सफिशिएंट टू सॉल्व दिस एमसीक्यू. इतने सारे लॉजिक में जाने की जरूरत भी नहीं है, बिकॉज इन द एक्चुअल एग्जाम, बिकॉज यू आर हैविंग लिमिटेड टाइम एट योर डिस्पोजल, सो यू नीड टू आई मीन गेट दीज फैक्ट्स राइट. चलो जी, let's move on to the 13th one for today. The kid is having loose motions and the mother is giving ORS to the child. The child is having a doughy skin. He is very lethargic, obviously because he is having dehydration, so the child is bound to be lethargic. The heart rate of the child is on the higher side, about 110. Orthostatic hypotension is also described, so that's understandable. He says which electrolyte imbalance would be present in this case. So let's guys, for question number 13, currently on the slide, which do you think is the electrolyte imbalance which is responsible? And the options are hyponatremia. You can close the slide and work it out again. It's less sodium, then is more sodium, then is potassium, and then is gonna be magnesium deficiency. I mean, I think now the options are visible. Screen not visible. I don't think so, doc. Maybe you can just close the close your YouTube video. Okay, got it. I think now it is visible, doctor. It should be visible now. Yeah. Let me just jot it down. It is visible, guys. Sodium is less, sodium is more. Then is gonna be potassium that is more, and then magnesium that is less. So these are the four options. I think I can erase this one and you can focus on the current one. This would make it easier for you. Okay, so I'm getting various answers for this one. Okay. See guys, the key word that you should be aware of is the doughy skin. एंड डो स्किन मतलब जैसे आटे वाली स्किन होती है ना, डो क्या होता है, जैसे आटा होता है ना, पिज्जा आप ऑर्डर करोगे यू नो, तो आई मीन दे विल मेक दैट डो. तो डोई स्किन इज अ फीचर which is gonna be very characteristic with respect to increase of sodium in the body. This answer to this one is not option number A, guys. You missed this word. You have to pick up that keyword in the question. The keyword in the question is doughy skin in this case. So the answer is not A, as I explained. I said you need to basically focus on the keywords which are present in the question. Most of the time what happens is Dr. Shukla, I could not pick up your query, so I think you'll have to post your query once again. The basic concept behind this question is कि ORS जब देते हैं ना, तो ORS जो होती है बहुत बारी मदर improperly dilute करके देती है. तो अगर नेक्स्ट छोड़ दीजिए, अभी आप एग्जाम्पल कंसेप्ट पढ़ लीजिए. जो बीमारियां अगर आपको बेसिक डिजीज आते हैं तो नेक्स्ट को टेंशन करने की जरूरत नहीं है. चलो मैं कंसेप्ट देता हूँ. सर ओआरएस जो होता है ना, उसको 1 लीटर पानी में डाइल्यूट करना होता है. पर आपने कभी खुद ओआरएस पिया हो तो ओआरएस विल टेस्ट वेरी रियली हॉरिबल. सो व्हाट मदर विल डू इज दैट शी विल डाइल्यूट द ओआरएस इन लेस अमाउंट ऑफ वाटर. एंड इफ यू गिव इम्प्रॉपरली डाइल्यूटेड ओआरएस, improperly diluted ORS देने से क्या होगा कि it will be causing more sugar to go in the body, and that sugar will cause worsening of diarrhea. So lots of time you will be having cases where you give ORS, mother is saying कि उससे लूज मोशन बढ़ गया है. वो लूज मोशन क्यों बढ़ जाएगा? क्योंकि उसने ठीक अमाउंट ऑफ पानी में डिजोल्व नहीं किया था. और जब बॉडी से पानी का लॉस होगा, ओनली वाटर का लॉस होगा, तो द सोडियम वैल्यूज इन द बॉडी विल बी बिगिनिंग टू राइज. This is one of the leading reasons why we would be having the problem. Guys, the correct answer for this question is option number B, that is hypernatremia. You have to first pick up the word doughy skin. उसी से क्वेश्चन सॉल्व हो जाता. एंड हाइपरनेट्रीमिया हैज हाइपोटेंशन. यही तो बात है कि पानी का लॉस हो गया ना, यही तो समझना है सर. इलेक्ट्रोलाइट इम्बैलेंसेस, तभी तो बोला कि भाई पढ़ लो, बिकॉज इस पे सवाल आते हैं. Hyponatremia is associated with, this is hypernatremia is associated with hypotension. That is the point that you have to understand कि भाई कैसे हो जाता है, कि मेन तो वाटर का लॉस हो गया ना इसमें. That is how the correct answer is option number B for this question. Hyponatremia is not the answer, and hyperkalemia तो होना ही नहीं था, डायरिया में हो नहीं सकता, तो C तो वैसे निकाल दो. और हाइपोमैग्नीसीमिया तो मैग्नीशियम पे भी आएंगे. आई मीन आपको मैग्नीशियम यहाँ पे कहाँ आंसर करना होता है वो भी अभी आपको बताऊंगा. वेयर शुड यू बी आंसरिंग हाइपोमैग्नीसीमिया, दैट विल कम इन द एमसीक्यू सब्सिक्वेंटली. लेकिन आपको ये बेसिक डेटा तो आना ही चाहिए. चलो जी आगे चलते हैं. लेट्स मूव ऑन टू द सब्सिक्वेंट वन. अगली बार का कंसेप्ट समझ लेना, कभी भी डोई स्किन सवाल में लिखा होगा तो हाइपोनेट्रीमिया मत आंसर करना, हाइपरनेट्रीमिया बोलना. बाकी हाइपरनेट्रीमिया होता क्यों है, तो पोटेशियम की वैल्यू बढ़ती क्यों है, तो सबसे इंपॉर्टेंट रीजन तो है जेरियाट्रिक एज ग्रुप में. दैट ओल्ड मैन अंडरवेंट अ सर्जरी, तो सर्जरी की वजह से ही मे नॉट बी एबल टू गेट अप फ्रॉम द बेड एंड ड्रिंक वाटर. आई मीन इफ आई डोंट ड्रिंक वाटर, द सोडियम इन द बॉडी विल बिगिन टू राइज. देन टू इंपॉर्टेंट कॉजेज आर सेंट्रल डायबिटीज इंसिपिडस, एंड देन इज गोना बी नेफ्रोजेनिक डायबिटीज इंसिपिडस. हाइपोमैग्नीसीमिया के फीचर हाइपोकैल्सीमिया के होते हैं ना, मैग्नीशियम कम हो जाए तो फीचर्स टेटनी वाले आ जाते हैं. टेटनी वाले होता है ना, कार्पोपिटल स्पैज्म, चोवोस्टॉक्साइन, पेरियोरल एंड पेरिएंगुअल पैरेस्थीसियास. तो दैट इज द रीजन. ओके जी. सो आई मीन क्यों सोडियम बढ़ता क्यों है, तो लीडिंग रीजन है inability to drink water due to old age, which may be because he's a wheelchair bound patient of Parkinsonism. He's a wheelchair bound patient of Alzheimer's disease. Then person can't go and drink water by himself, or he doesn't know what is the reason route to the kitchen in Alzheimer's disease. So deprivation is one of the leading reasons. Then is central and nephrogenic diabetes insipidus. And then look at this surprising statement, diarrhea is the most common GI cause of hypernatremia. Mostly डॉक्टर क्या पढ़ते हैं कि भाई डायरिया में हाइपोनेट्रीमिया तो होता ही है, बट डायरिया में हाइपरनेट्रीमिया में भी होता है. और डायरिया में हाइपरनेट्रीमिया क्यों होता है, उसका रीजन होता है कि अगर आपने ओआरएस को ठीक से डाइल्यूट नहीं किया तो बॉडी से पानी निकल जाएगा, और सोडियम की जो कॉन्सेंट्रेशन है, द वर्ड इज सोडियम की जो कॉन्सेंट्रेशन है वो बढ़ जाती है, which is responsible for this manifestation. So hi Faraz, good to see you guys attending this session. And mainly आपको एक causes of hypernatremia आने चाहिए, at least 3 आने चाहिए, 4 basically. One is gonna be diminished access to fluids due to old age, central and nephrogenic diabetes insipidus. Then even diarrhea can contribute to hypernatremia. Then are like mannitol and insensible losses. वो चलेगा मतलब even if you don't remember. But these are couple of them. And if sodium is elevated, if sodium goes more than 158 milliequivalents, then patient को सीजर भी हो सकते हैं. sodium values more than 158 milliequivalents can contribute to development of seizures. And if you will say what fluid will be given for management of hypernatremia in the patient, then the single best answer would be that I'll be giving to the patient 5% dextrose. That is the first answer that is to be given in the question. The answer will depend upon what is the reason behind it, right? Dr. Alia, for hypo and hyperkalemia, you need to go back to yesterday's video where we have discussed it. So for today, we are focusing on the sodium component. If he says what is the fluid of choice for management of hypernatremia, your answer is 5% dextrose, because that's the usual situation that we have, hypernatremia with euvolemia. Though there are multiple permutation combinations जो हैं वो भी are basically responsible. ओके, ओआरएस को यार 1 लीटर पानी में डिजोल्व करना होता है, क्योंकि टेस्ट अच्छा नहीं होता तो मदर उसको कम पानी में डिजोल्व करती है। तो अगर कम पानी में डिजोल्व करेगी तो मीठा हो जाएगा, मीठा होगा तो बॉडी में शुगर जाएगी, और शुगर ऑस्मोटिक मॉलिक्यूल है तो पानी खींचेगा, और जब बॉडी से पानी निकल जाएगा, सोच के देखो सोडियम कॉन्सेंट्रेशन होता है तो सोडियम डिवाइडेड बाय वाटर इन द बॉडी, अगर अपने बॉडी से पानी खींच लिया तो सोडियम की जो कॉन्सेंट्रेशन है वो बढ़नी शुरू हो जाती है। दैट इज वाई मैंने बोला रिलेटिव हाइपरनाट्रीमिया विल बी प्रेजेंट। सो आई थिंक सुभाष अभी क्लियर हो गया होगा। ऑस्मोटिक डायरिया कंसेप्ट समझ लेना कि भाई, और मतलब हम बच्चे को यार डायरिया में मदर को बोलते हैं ओआरएस दो, कहती है मेरा बच्चा तो जी फ्रूटी पीता है, तो डायरिया में फ्रूटी दोगे? नहीं दोगे ना। वो कहती है मेरे तो रियल का जूस पीता है, तो रियल का जूस भी नहीं अलाउ करोगे। वो क्यों जूस नहीं अलाउ करे? मीठा है ना भाई, वो शुगर जो है पानी खींच लेगा। हाई मदर आई, वो कहती है जी मेरा बच्चा तो रियल का जूस पीता है ना। या तो हम तो जी कोल्ड प्रेस वाला जूस पिलाते हैं बच्चे को, हमने मशीन रखी हुई है कोल्ड प्रेस वाले जूस वाली, तो आप मना करते हो उसके लिए। दैट्स द रीजन ना भाई, शुगर विल ड्रॉ इन वाटर एंड विल कॉज ऑस्मोटिक डायरिया। एनीवे, कमिंग बैक टू द डिस्कशन, फॉर hypernatremia the main fluid to be used is water ingestion and IV 5% dextrose. If he's having seizures, then I can't give water. Like suppose he says that the sodium value of the patient is about 152 milliequivalents. Suppose in the MCQ he says sodium in the body is 152 milliequivalents and there is no seizures in a patient, and he says कि क्या करोगे? तब आपका आंसर होगा water ingestion, by make the person drink as much water as possible. But suppose I increase this to in excess of like 158 and then he says कि भाई अब क्या करोगे? Then the answer would be 5% dextrose for the person. So these are two important aspects that should be basically remembered. At value 152 it's gonna be like 150 152. I'll try to do this. Okay, chalo ji, I think we are sorted for this concept of doughy skin. That's the key word for this question in hypernatremia, and now we are in a position to take up the next MCQ. Which of the following is a leading cause of asymptomatic hypercalcemia? Yes guys, let's have a look at the options. अरे options इसमें थोड़ा सा हाइड हो रहे हैं, so I think मुझे लिखने पड़ जाएंगे फटाफट से। तो एक तो लंग कैंसर तो दिख रहा है, खैर है ना, लंग कैंसर is visible, then is gonna be parathyroid adenoma. I think the color contrast is causing that issue. Then is sarcoidosis, if it's not visible, and then is Milk-Alkali syndrome. So I think guys, you can quickly comment on if it is not visible on the screen. I've just jotted down the options here. Leading cause of okay जी, C आंसर आ रहा है sarcoidosis, फिर आ रहा है Milk-Alkali syndrome. तो Milk-Alkali syndrome क्या होता है? तो मिल्क अल्कली सिंड्रोम, तो यार मिल्क अल्कली सिंड्रोम पर से इज गोना बी ड्यू टू एक्सेसिव एंटासिड यूज ना। एंटासिड का यूज भी क्या, एंटासिड का जो अब्यूज होता है, इट इज एंटासिड अब्यूज, एंड एंटासिड्स वुड बी हैविंग लॉट ऑफ बाइकार्बोनेट, सो दैट विल and would be having calcium also. So like Digene gel would be having calcium, so the values of calcium would be increasing subsequently. Okay, cool guys, if the screen is clear then it's okay. Maybe it was not visible last time. So let me give an explanation for milk alkali quickly. Milk alkali basically is antacid abuse, and this antacid excess in the body will cause the calcium values to rise, because that would be having calcium also. तो मुझे मल्टीपल आंसर्स मिल रहे हैं यहाँ पर, बी सी डी सारे ही हो गए हैं, तो हमें बोलना है asymptomatic hypercalcemia. Asymptomatic is always going to be a presentation related to parathyroid adenoma. The correct answer for this question is option number B. And if we say symptomatic, then it is obviously a malignancy. But asymptomatic कभी भी लिखा होगा तो parathyroid adenoma. Later part of parathyroid adenoma, obviously there would be moaning and groaning and bone pain. But initially, when parathyroid adenoma will grow, it will grow relatively slow, and that is why the manifestation would be developing. So, Guys, I think most guys have subsequently got this one right. Farman, Abhijit, and Dr. Sham. I think most guys have got it subsequently correct. So moaning, groaning, bone pain आता है, but that would be a late manifestation of the disease. The correct answer for 14 is option number B. Let's move on to the next one. Leading cause of symptomatic hypercalcemia. This time I've changed the options. I have also given a hint also with respect to malignancy. So I think I'm making it easier for you guys. Which of the following would be responsible for symptomatic hypercalcemia? And once the calcium values will start spiking in the body, the biggest risk with elevated serum calcium is systolic arrest of the heart. Like potassium is elevated, it can cause a diastolic arrest. If calcium is elevated, systolic arrest can occur. So, yep, I think more people can quickly comment in the chat with respect to symptomatic hypercalcemia. It's going to be lung cancer, and which lung cancer would be causing it? The lung cancer responsible for this would be squamous cell cancer. Squamous cell cancer क्या करता है? वो PTH रिलीज करता है. PTH RP क्या होता है? Parathormone related peptide, and this parathormone related peptide would then be causing a spike in the calcium value. So leading cause of symptomatic hypercalcemia is lung cancer. Sarcoidosis में नॉन केजेटिंग ग्रेनुलोमास होते हैं, बट एट द सेम टाइम अगर ओवरऑल देखा जाए प्रेवलेंस वाइज, then the leading cause of symptomatic hypercalcemia is lung cancer. ये नहीं कह रहा कि lung cancer is more common as a disease as compared to sarcoidosis. What I'm trying to say is that hypercalcemia, if is a presentation, then lung cancer is relatively a much more common cause because of production of PTH per se. So we are sorted for both 15 and 14, 15 points. तो याद कर लेना. Asymptomatic hypercalcemia तो parathyroid adenoma. If it's gonna be symptomatic hypercalcemia, it's gonna be squamous cell cancer. And let's move on to the 16th one for today. A patient with diabetic nephropathy is having an estimated GFR of 20 ml per minute. So the grading is pretty nasty. I mean, person is gonna be very soon going into from grade 4 to grade 5 CKD. And at this point of time, there are bound to be electrolyte imbalances. There are bound to be metabolic problems in the patient. He says, which of the following is likely to be present in this case? Waiting for your comments in this particular case. I mean, every time the kidney would be compromised, it will be having inability to excrete hydrogen and potassium. So I think option number A can be easily ruled out, because kidney जब भी खराब होती है तो potassium and hydrogen is not excreted, which is why we always get a hyperkalemic metabolic acidosis. So option A can be easily ruled out. Let me just look at what you guys are saying for this one. Yep, guys. And every time GFR will be less, the renin values will also be elevated. So it cannot be low renin hypertension. No, it will always be a high renin hypertension. When condition causing low renin hypertension is an endocrine topic, Conn syndrome. Low renin hypertension can be seen in Liddle syndrome. I mean, Conn's and Liddle's are situation where you read about low renin hypertension, but otherwise most of the conditions that you get are always going to be a high renin hypertension in a patient. So 2 I've already ruled out for you guys. We are left between phosphate aspect and we are left between acidosis in the patient, that is normal anion gap. So whenever kidney is damaged, we get a HAGMA, right? High anion gap metabolic acidosis. And here option D is giving normal anion gap metabolic acidosis. So you have to solve this question by exclusion, and by exclusion the workout is, and I think most people would have been able to get this one right. Why? Because I've already always highlighted this fact that every time you are having a CKD present, what you will always look for is phosphate. He would love to ask you regarding what's going to happen in phosphate with respect to a patient who is suffering from CKD. It's mainly going to be hyperphosphatemia as one of the leading reasons. And that phosphate will then bind to calcium. वो calcium से क्योंकि bind कर जाएगा तो hypocalcemia develop हो जाता है. तो किडनी कभी भी खराब होती है तो इलेक्ट्रोलाइट्स में हमेशा क्या क्या मिलेगा आपको? पोटेशियम बढ़ा हुआ मिलेगा, फॉस्फेट हमेशा बढ़ा हुआ मिलेगा, रेनिन हमेशा बढ़ा हुआ मिलेगा. 3 चीज़ें हमेशा बढ़ी हुई मिलती हैं, पोटेशियम, फॉस्फेट और रेनिन. और क्या क्या कम हो जाता है? तो ड्यू टू एक्स्ट्रा वाटर इन द बॉडी, सोडियम वैल्यूज विल बी लेसर, कॉन्सेंट्रेशन वाइज सोडियम विल बी लेसर इन द पेशेंट. Similarly, calcium will be bound to phosphate, so it would be less. Erythropoietin values would be less in the patient. So I think, yeah, Lalit, I think this was an easier one to be picked up. I mean, CKD patients, the derangements that are present. जब भी CKD का टॉपिक पढ़ोगे ना, उसमें बस ये देख लेना क्या चीज़ बढ़ रही है, क्या चीज़ कम हो रही है, because the MCQs would be of all except variety, by which you will be able to solve these questions. Okay, so good. I think majority of guys, hypotension develops after ESRD. Doc, initially it will be ESRD causing hyper, but then after dialysis, there can be a development of hypotension in the patient as well. Let's move to the next one for today, and this talks about a sick child who is admitted with diarrhea. He's having recurrent episodes of seizures as well. The patient is afebrile because you are thinking he is having a CNS infection that can be causing seizures. So you did a lumbar puncture. The lumbar puncture is normal, and then the child is showing hyponatremia. Sodium is very low. I mean 122. Anything less than 125 is always dangerous. Today we have learned that hyponatremia and hypernatremia both can be present in diarrhea. Presentation I have explained. I mean पेशेंट आएगा हाइपोनेट्रीमिया के साथ में, ओआरएस इम्प्रॉपरली डाइल्यूटेड देंगे तो हाइपर हो जाता है. ओके जी, सो लेट्स लुक एट व्हाट यू गाइस आर सेइंग फॉर दिस वन. व्हाट शुड बी डन टू कंट्रोल द सीजर्स इन दिस पर्टिकुलर चैप. वी नीड टू गिव, आई मीन मैं आके बोलूंगा तो आंसर क्लियर हो जाएगा, तो आई एम वेटिंग फॉर यू गाइस टू कमेंट फॉर दिस वन. आई मीन वी आर टॉकिंग अबाउट डेंजरस हाइपोनेट्रीमिया. जब भी सोडियम की कमी होती है तो सोडियम की कमी में आपको सोडियम को बढ़ाना है. सो वन आई कुड पिक अप वाज अ सी स्लो इन्फ्यूजन ऑफ 0.45% saline and 5% dextrose to bring sodium more than 125 milliequivalent. So I think you would agree to the fact that 0.45% saline will not be having sufficient amount of sodium present to cause a rise of sodium values. So what I need to give to this patient is hypertonic saline. So one, I think everybody should be able to think about this fact that we have to give 3% saline for this person. The answer cannot be C and D because C and D would be having very less amount of sodium present, and therefore the sodium values will take a very long time to rise. Now we are left between point number 1 and point number 2, and I got like answers like B also, slow infusion of saline to bring sodium. तो वी आर पॉइंट ये है कि स्लो इन्फ्यूजन इज डन इन पेशेंट्स ऑफ क्रॉनिक हाइपोनेट्रीमिया. जो ऑस्मोटिक डीमाइलिनेशन आप सोच रहे हो ना, दैट इज गोना बी सीन विद क्रॉनिक हाइपोनेट्रीमिया, नॉट विद एक्यूट ऑनसेट हाइपोनेट्रीमिया. फॉर एक्यूट ऑनसेट हाइपोनेट्रीमिया जे दैट्स ओके, वो जो ऑस्मोटिक डीमाइलिनेशन सिंड्रोम है ना, आप 122 से 125 ही तो बढ़ाना है, 3 ही तो पॉइंट बढ़ाना है. वो जो स्लो आप पढ़ते हो ना कि भाई डेली 8 पॉइंट्स इंक्रीज करना है, दैट इज फॉर क्रॉनिक हाइपोनेट्रीमिया ना पेशेंट. यहाँ पे तो you need to increase only from 122 to 125. That's an increase of 3 points only. So you will give a bolus for this patient. The correct answer for this one is option number A. The basic concept is that if you are having acute onset hyponatremia, so you need to increase by only few points. No, like patient came at 122, so I need to increase from 122 to 125. That 3-point increase will not cause osmotic demyelination syndrome. It's only a 3-point increase that is happening. So for acute onset hyponatremia, it is a rapid correction which is to be done. क्योंकि मैं स्लो करूंगा तो सीजर कंट्रोल कैसे होंगे? अगर मैं स्लो करूंगा तो सीजर तो टर्मिनेट ही नहीं होगा पेशेंट का. So it is chronic hyponatremia where we go in for a gradual correction, where we talk about that 8-point का correction. So please be clear about this basic differentiation that बोलस है तो मतलब उसको फास्ट देंगे ना, ताकि हम उसका रैपिड करेक्शन करेंगे ताकि सीजर्स कंट्रोल हो जाए. हमारा भाई पर्सन इज हैविंग कन्वल्जन, तो आई विल नॉट वेट फॉर लाइक वन डे फॉर देम टू बी टर्मिनेटेड. आई विल गिव माई सेल्फ a reasonable amount of time to upgrade from 122 to 125, which is why the correct answer for this one is option number A. So ये concept basically आपने याद रखना है कि it's only a 3-point increase that you are doing. It's not that you're doing a 10-point increase, or it's not that you're doing a 20-point increase. I mean, if I was saying ki from 122 in like 1 hour, I will go from 122 to 135, no, that is a problem. But to upgrade from 122 to 125, well, that's not big deal, which is why the answer for this question is option number A. So this question was deliberately can control on increasing Dr. Parvez will not get into the values of the bolus dose that will be going at the moment. Let's focus on the main aspect. Okay. Yeah, for us that's the important point, because everybody is going to talk about ODS here. But I mean, every time we read about sodium, no, it's always about ODS. All examiner bodies love to ask about osmotic demyelination syndrome. That's okay, but if it is gonna be नॉर्मल किसकी वैल्यू पढ़नी है? सोडियम की, पोटेशियम की, कैल्शियम की, 3 तो पढ़ लो. Sodium, calcium and potassium. Okay ji, fine. We are sorted for question number 17. Let's move on to the next one. He says pseudo hypokalemia occurs due to which of the following? Pseudo मतलब false होता है, तो भाई false बताना है कि भाई क्या हो रहा है. नॉर्मल जो सोडियम है 3.5 से 5.5 है, रिपोर्ट में कम आ रहा है, लेकिन आप उसको सूडो बोल रहे हो, तो देखना है कि भाई क्यों ऐसा हो रहा होगा. चलो गाइस फटाफट से कमेंट करो ए बी सी डी में जो तो. चलो ए पे पहले आ रहा है, जैसे ए का आंसर आ रहा है यूज ऑफ थिन बोर नीडल इन वेने पंक्चर. तो ये जो ऑप्शन नंबर ए है उसमें मुझे बताओ कि सूडो हाइपोकलीमिया होगा या सूडो हाइपरकलीमिया होगा, क्योंकि अगर आप थिन बोर नीडल यूज करोगे तो थिन बोर नीडल यूज करने से आरबीसी टूट जाएंगे, और अगर आरबीसी टूटना शुरू हो जाएंगे, इफ द आरबीसीज विल ब्रेक डाउन देन दे विल कॉज अ हाइपरकलीमिया इन अ पेशेंट. सो ए को तो सिली मिस्टेक बोलेंगे. इट वुड नॉट बी अ थिन यूसेज, इट वुड बी अ थिन बोर नीडल इन वेने पंक्चर. तो यार वो तो सूडो हाइपर कलीमिया कर देती है. और जेटलमैन सिंड्रोम और गॉर्डन सिंड्रोम, जेटलमैन क्या होता है, उसमें डिस्टल कॉन्वल्टेड टिब्यूल में जो सोडियम क्लोराइड ट्रांसपोर्टर होता है, वो सोडियम क्लोराइड ट्रांसपोर्टर का लॉस ऑफ फंक्शन होगा. और गॉर्डन सिंड्रोम उसका ऑपोजिट होता है, इसमें डिस्टल कॉन्वर्टेड टिब्यूल में जो सोडियम क्लोराइड ट्रांसपोर्टर होता है उसका गेन ऑफ फंक्शन होता है. तो ये तो जो भी इलेक्ट्रोलाइट इम्बैलेंसेस करेंगे वो जेन्युइन करेंगे ना. Gentleman syndrome and Gordon syndrome are opposite of each other with respect to one having a loss and other one having a gain of function of the sodium chloride co-transporter. So the point is, one, they will not affect potassium in a very big way, and even if they do, the point is sodium chloride transporter, if it is being affected, then it will obviously affect the electrolyte. That is a genuine thing. So you have to solve this question by exclusion in this case. The correct answer for the current question on the slide is option number B. दैट इज इन विट्रो कंजम्पशन. मतलब जो वायल है ना उसमें आरबीसी ज्यादा है. जैसे आपने लुकीमिया वाले पेशेंट का ब्लड सैंपल लेके रख दिया, तो लुकीमिया वाले पेशेंट में क्योंकि टीएलसी ज्यादा होता है, टोटल ल्यूकोसाइट काउंट ज्यादा होता है, तो द सेल्स विल टेक अप, देयर वुड बी इंक्रीज अपटेक ऑफ पोटेशियम बाय द सेल्स. The cells will try to take up sugar, they'll try to take up potassium also. So increased uptake of potassium is seen, which leads to false hypokalemia. There are two concepts which are to be remembered. One is pseudo hyperkalemia, second is gonna be pseudo hypokalemia. Pseudo hyper क्यों होता है? If you use a पतला needle, भाई जो इंजेक्शन लगाने वाले नीडल है, आईएम इंजेक्शन के लिए जो नीडल यूज कर रहे हो वही आप ब्लड सैम्पलिंग के लिए भी वेने पंक्चर के लिए यूज कर रहे हो, 23G यूज कर रहे हो, देन इट विल कंट्रीब्यूट टू इश्यूज इन अ सेंस फॉल्स एलिवेशन. मतलब बेसिकली ये वन लाइनर सवाल है. It's gonna be like pseudo hyperkalemia seen in pseudo hypokalemia seen in. तो आई थिंक सबको याद हो गया होगा. मैं फिर से लास्ट टाइम फिर से रिपीट कर रहा हूँ. सूडो हाइपरकलीमिया लिखा होगा तो अब आंसर बोलना थिन बोर नीडल. अगर वो बोलेगा सूडो हाइपोकलीमिया तो आपका आंसर होगा कि लुकीमिया का पेशेंट है जिसका सैंपल लेके आपने रख दिया वायल में, तो इट विल कंज्यूम शुगर, इट विल कंज्यूम पोटेशियम आल्सो, एंड देयरफॉर द वैल्यूज वुड बी रिलेटिवली लेसर. So J will MCQs will gradually become, and that what happens in exam also. Initially everything is easy, then things become a little more tricky ones. So anyway, I think we are sorted for today's question, and yep, I think this would be beneficial for you in a sense कि आपको practice करनी है ना, कि भाई जैसे कई questions बड़े regular से होते हैं. जैसे regular वाला question कौन सा है, तो वो मैं ये वाला दिखाता हूँ. Like diabetic nephropathy, kidney is involved, so potassium phosphate will be elevated. This is like a regular bread and butter kind of an MCQ. Then they'll give you a question in which we'll think in terms of कि यार chronic हम सोच रहे थे, acute निकल गया, and then we have to pick up the words, right? Pseudo hypokalemia, और हम जल्दबाजी में हमने पढ़ा क्या pseudo hyperkalemia. So I mean that is what causes errors in the exam. आपको easy मिलेगा, फिर आपको थोड़ा सा मिलेगा जो पढ़ा हुआ होता है. Like this is an example of what you have read but not understood, and this is कि शायद ये कभी पढ़ा नहीं होता most of the time. शायद मैंने भी नहीं पढ़ा होगा pseudo hypokalemia, but then questions like these would actually come in the exam. So it's a balanced view that you need to keep. And गलत होने से यार परेशान नहीं होना होता है. बेसिकली मैं हर बार यही बोलता हूँ कि मेंटल स्ट्रेंथ वही होती है कि लाइन से 5 गलत हो जाए फिर भी सही करके आ रहे हैं, आगे वाले सही करके आ रहे हैं, जो गलत हो गए उसका तो कुछ नहीं हो सकता. ओके जी, तो 19th पे आते हैं आज के लिए. PM grade 3 child was admitted with an episode of diarrhea and the serum potassium of the patient is low. Therefore potassium chloride replacement was given. but the child is still having a floppy neck. Floppy मतलब ऐसे उसकी गर्दन बिल्कुल लूज हो रही है. The muscle tone is less in the patient. So in those circumstances, if you're gonna be having low potassium, in spite, I mean potassium का आप potassium कम था तो replacement was given. तो अब हाइपोगोलीमिया तो नहीं होगा उसको ना. अगर आपने रिप्लेसमेंट गिवन है तो देन इट विल नॉट बी हाइपोगोलीमिया. सो ही बेसिकली वांट्स टू सी दैट malnourished बच्चों में और कौन सा इलेक्ट्रोलाइट इम्बैलेंस होता है which will result in hypotonia. This is a repeat question from 2020 exam. This was asked in NEET PG and was asked in even FMG exam 2020 exam, which was supposedly a difficult exam. The point is, if in spite of hypokalemia, if the muscle weakness is persisting in a patient, then it is always magnesium deficiency. Answer to this one is option number A. Good, I think most guys have got this one correct because this was a PYQ kind of a question. So we have a balanced approach whenever we are trying to solve these MCQs. Yes, Arshjan, you are right. This is a PYQ. That is why it has been kept today. So great. Let's focus on the last one for today. He says, which of the following is not correct about diarrhea with severe dehydration? Here the not word is anywhere to be remembered. Oh, okay, great. So he says, good Kirti, low muscle tone asked for your exam. Okay. Good that you remember that question. Which of the following is not correct about diarrhea with a severe dehydration? Yes. Chalo ji, let's work it out. Anion gap is a difference of sodium minus the negative charges, that is going to be chloride and bicarbonate. So I'm going to work out the normal before you while you give me the answer to this question. Normal is going to be sodium is 140, chloride is about 106. Bicarb is about 24. So if you take the whole thing here, 140 minus 130, that would be 10 milliequivalents, and the normal anion gap is gonna be in the range of about 6 to 12 milliequivalents per liter. And he says that which of the following is not correct. I'm getting a B initially, negative urinary anion gap. So I will always explain this fact that with respect to diarrhea, you will be having a negative. I mean negative को कैसे याद करना होता है? That is gut. Negative के spelling तो NEGA होते हैं, but वो gut से याद करना होता है. The diarrhea में negative urinary anion gap होता है. So this would be a correct statement. And then he says positive serum anion gap. So that's also true because diarrhea will be responsible for development of a anion gap in a patient. And diarrhea will cause lactic acidosis also. Why? Because there would be a perfusion aspects in a patient. And whenever perfusion of cells is less, then the cells will go into anaerobic mode of respiration. They will be producing acid. I mean type A lactic acidosis होता क्या है? Type B तो होता है drugs से. Metformin, fenformin, that is type B lactic acidosis. But type A का concept होता है perfusion is less. If the perfusion of any tissue is less, the cells will go into anaerobic mode of respiration, and that can contribute to development of lactic acid, and that's why type A lactic acidosis would be present. So we have to select between option number A and option number D only. I mean, I've explained negative urinary anion gap. I said diarrhea or hack बताया. I can get into the mathematics of that also. The urinary anion gap. Normally, जो urinary anion gap होता है, that is gonna be 0. Normally, urinary anion gap is gonna be 0, but in diarrhea cases, it would be negative. So that is a point worth remembering. That type A lactic acidosis. So I think we're pretty sorted for this one. A versus D ही select करना है. And in one we are having a hypotonic hyponatremia, then we are having a positive serum anion gap in a patient. So diarrhea can usually result in development of a high anion gap metabolic acidosis. It usually results in normal anion gap acidosis in a patient. Here is written the word positive, so it's a very non-specific term because positive to रहना ही रहना, right? It will always be positive. So what I'm trying to say is that anion gap is usually is gonna be normal in diarrhea case, and it's gonna remain on the positive side only. So this is the correct statement. The wrong statement here is option number D. That is gonna be hypotonic hyponatremia. हाँ, right. वो anion gap का mnemonic तो यही है ना कि वो Dr. Fuse वाला mnemonic है यहाँ पे. The diarrhea will be Dr. Fuse, that is NAGMA, that is normal anion gap metabolic acidosis. तो वो वहाँ पे लगाना था, पर वो क्या है कि क्वेश्चन में उसने ये नहीं लिखा ना कि हाई नॉर्मल है या अनायन है, बट पॉइंट है कि नॉर्मल मतलब पॉजिटिव ही होता है. तो दैट्स ओके स्टेटमेंट. आई मीन दैट्स आई वुड से प्लेइंग विद इंग्लिश इन दिस पर्टिकुलर क्वेश्चन. द करेक्ट आंसर फॉर दिस वन इज ऑप्शन नंबर डी. So I think this was a little faster session that I conducted today because we wanted to decrease the speed, decrease decrease the time response of ours when it comes to solving multiple choice questions. Yesterday we took a relatively longer time because we had just started these sessions. So we are going to continue with this on a regular basis. वो छोटे छोटे targets हैं जो आपने daily achieve करने हैं. तो हाँ जी हर्ष वही वही पॉजिटिव होगा. That's another way. That's another way to remembering. So great guys, I think we are sorted for today's discussion. हाँ जी राहुल साहब, I'll be taking multiple sessions subsequently also, and FMGs के लिए they're much more lined up on the prep letter channel as well. So I mean there's a lot of data coming your way. It's just that आप कितना उसको utilize करते हो effectively. That's sort of paramount importance. So yep. Hi Ronak, very good evening to see you, and we are actually towards the end of our discussion. So this is going to be posted in the PDF of this would be available in the Telegram group. You can join there, and yep, I'll be declaring another session on a different date where we'll take up another topic. But then from these 20 questions that we've discussed overall from the electrolytes, try to see how many of you got right, and just try to minimize your silly mistakes. That is what is optimally required for your performance. So thank you so much, and God bless you. Doc, tomorrow we are not doing a session. The date for that would be declared very soon, but the electrolyte part I've taken care, so please take care of that as of today. So take care, and I know it's wedding season and everybody else is busy in weddings and you are studying, but then it will pay you off in the long run, so don't worry. I mean, everybody is in their own time zone. Important topics list, okay Doc. So Vinay, it will show up very soon after, because we had to discuss these questions also. And important topic list, happy आप electrolyte करो अभी तो. I mean, the list will follow. We have 1 month available now, so I'll be taking multiple sessions in which I'll be covering all the important topics which are relevant for the exam. Yes, Omkar, we'll be doing a session for ECG also. Don't worry, I mean, that ECG part will also be coming. So okay guys, thank you so much. God bless you. डाउट्स के लिए मेरा ईमेल है, लिख लीजिए डॉक्टर साहब, marvamedicine@gmail.com. I'll just bring the slide up again. You can drop me an email at this particular link, that is marvamedicine@gmail, and I shall be glad to assist you. हाँ जी ECG का सेशन करेंगे सर. चलो ओके देन, बाय बाय, टेक केयर. टेलीग्राम का लिंक इज इन द डिस्क्रिप्शन ऑफ द वीडियो बिलो. And shock also. Yeah, Jay, you've been asking for it, so I'll do shock, various varieties. Take care. Bye bye.